All right, so 2 articles for Journal Club today: Cardiopulmonary Resuscitation using electrically driven devices. And we have had a lot of Journal Club reviews on this topic, mechanical CPR, and regardless, the interest and the intrigue with this topic remains to be quite high. So that's number 1. And then number 2, obviously a personal passion of our practice, is the use of pre-hospital ultrasound. So this was a pilot study done by Dr. Laleh Gharabagan in Stanford. So excuse me for butchering that name, but very famous sonographer at Sonospot on Twitter. Pre-hospital evaluation of effusion, pneumothorax, and standstill. Point of care ultrasound in EMS. So Navin, you want to take the first one?
Yeah. So with the pre-hospital point of care ultrasound in EMS, I found that this article was very interesting because prior articles that we reviewed have been pre-hospital physician-driven ultrasound, but this study actually looked at EMT basics and EMT paramedics, and also students, EMT students, both basic and paramedic, and trained them, short training interval for point-of-care ultrasound, and then later looking at what they did with that and whether or not they were actually able to get the images that they needed and actually interpret them properly. This was a prospective study, I believe, that looked at this. They enrolled about 57 pre-hospital providers, specifically 19 EMTB students, 16 paramedic students, 18 EMT basics, and 4 certified paramedics. The pre-tests, they did a pre-test to see what they knew, and they found that they had about a rate of 65%. The post-test was over 90%, which is very good. Prospective observational study is what was done. If you go to table 1, they were about half male, half female. Mean age was about 26. Highest education was 4 of them had master's degrees, 38 high school graduates, 14 were undergrad. And prior ultrasound experience, 46 or over 80% of them had no prior experience with ultrasound, which is good for this kind of study. Specifically in figure 1, the pre and post test, looking at pneumothorax, 50% pre-tests they were able to identify. Later on, over 90%. Pericardial fusion, similar, and then cardiac standstill. Most people were able to identify that beforehand, but I think obtaining the images were the important thing. Anything else to add?
Yeah, there's so much.
Yeah.
So tell us a little bit about the design of the study. When were they training folks, and why did they choose EMTs and paramedics?
So the design itself is an observational study. So, prospective observational. One thing they did was they used students and they used already people who were kind of practicing, so well experienced. They were voluntarily chosen, so there were people who were a little bit more of a go-getters versus anyone else. But I think it's reasonable to use basics and paramedics just because you want the basics to actually be able to look at cardiac standstill, be able to realize that. And then your more advanced, your paramedics are going to be able to look at for effusions, and they're going to look for your pneumothoraces where they can intervene. From a basic level, though, you want to be able to say, okay, this is cardiac standstill, we're going to continue compressions, or we see actually, So I think it's important to incorporate all comers basically when you look at clinical ultrasound, especially because it's very teachable and it's very easy to learn, and you can see how the learning curve is very quick upstroke. You can just basically take some minimal information and you can precipitously learn very quickly.
Can you tell us a little bit more about how they were trained?
The way they had the training here, I think they had like a 1-hour course essentially is what they had. It was 1-hour training, and they basically went through and they kind of basically showed images, and they kind of showed them this is kind of what cardiac standstill is. And they showed them the normal anatomy essentially, and then they showed them kind of what pathology would be. And that's kind of how they went through basically demonstrating on ultrasound imaging kind of what to look for and what to see. Mm-hmm. But I think just like we do anything else, it's looking at normal first, understanding normal, and then looking at abnormal and kind of going from there.
And so in terms of pre-test and post-test, so this is a pilot study. Are they using actual patients, or exactly how are they structuring this?
This one, they are not using actual patients. Let me see what they
I
actually.
think they were using images, weren't they?
Test images, yeah.
Yeah, it wasn't actual patients that they were using, and these are very nice images that they were getting collected. So it wasn't like it's like the actual real patient where you're actually struggling to really find the image. It's actually these images are already pre-recorded and they're there for you. So you take away that kind of investigative part where you're actually looking for your image, getting your view, as we say it, basically, and then kind of interpreting the information from it. These views are pretty much provided for you, and they're classic views. And so this is kind of when we talk about discussion, where there's some flaws in some of the interpretation and being able to interpret the information, actually, more so than anything. But yeah, it wasn't real human models, no.
So I think, yeah, please.
They weren't actually looking at acquisition of images.
No.
Or the time involved to obtain those images.
Not at all.
And of course, obviously, it wasn't designed to look for any outcomes.
Correct. Yeah, so that's a great point. So there is some selection bias in choosing the participants, right? Because these are either EMT paramedic students or EMT paramedic providers, and they have some interest or they've volunteered for this study, showing that they're interested in gaining more or acquiring more knowledge regarding pre-hospital ultrasound. So the diagnoses that they chose were interesting. So pneumothorax, rapidly reversible pre-hospitally with significant potential changes to outcome. Effusion. So effusion in itself, when we look at that variable, can be likely to many different sources. Something that would be more pertinent to me would be for a dyspneic patients, the presence of B lines. And that's been something that we've been trying to prospectively validate, that both pre-hospital providers are able to acquire those images and interpret those images. So we still need further study along those lines. So I would have chosen B lines, I think,
100%.
over pneumothorax. And then finally, cardiac standstill. So this is an interesting and relevant one, and it's something that we aim to employ as well with physician-based pre-hospital ultrasound, is to help guide our termination of resuscitation. I think it's relevant that they used EMTs as well, because we know under the National Association of EMS Physicians, NAEMSP's TOR, or Termination of Resuscitation Guidelines, that they describe cardiac arrest as a BLS level skill. So focus on high quality compressions, supraglottic airway if your protocols allow it. Otherwise, we know we have a lot of folks doing CCR, cardiocerebral resuscitation with nasal cannula and non-rebreather mask. And then just focus on the resuscitation rather than the IV, the intubation, the medications. And in regards to their acquisition, so they're able to teach folks how to interpret images. But now, let's say you have an acutely dyspneic patient. You're trying to differentiate heart failure versus COPD. You've decided as a pre-hospital care provider to place CPAP, right? So many additional questions. Now, can you differentiate based on point of care ultrasound? Do they have B lines? Maybe take a quick look at their ejection fraction, and then you can titrate your therapy from there. Alternatively, another thing that we are so curious about is, can pre-hospital care providers effectively perform ultrasound without delaying transport to the emergency department? And this remains one of the areas of greatest controversy. Ideally, we'd like them to be on CPAP. We're heading towards the hospital, and en route, the provider is able to make that intervention and assessment, and it gives you both the ability to intervene diagnostically in the ambulance. We can say proceed with nitroglycerin versus continuous albuterol for heart failure versus COPD. And then obviously it'll give the emergency department some recon or some additional information that it may take several minutes, or even later on in the resuscitation, they may ultimately go ultrasound the patient. So lots more to be desired, but interesting pilot study that they did out in Stanford.
With the pre-hospital ultrasound especially, there's a huge problem in general with pre-hospital skills and skills maintenance for people who may not do certain skills often. I mean, we always talk about intubation skills for paramedics, and how people who have high volume exposure are generally better able to maintain their skills
Absolutely.
than people with low volume exposure. For ultrasound, I think the same thing applies. High volume exposure is going to make you better at it. Lower volume is going to be very difficult. And in fact, is it worth the cost of a multiple $1,000 unit and the time that you spend for somebody who may or may not, who may do 2 a year?
Yeah, absolutely.
Is that an expenditure that you may want to make?
I think that's a great point. However, that being said, I could tell you that you could make an excuse to use an ultrasound on every patient if you wanted to.
Sure.
And I agree with you, whether it changes your management is key. But certainly for cardiac arrest, I think it's great. So if you had, I would use ultrasound on every cardiac arrest. And if paramedics and basics were trained on this, I think they would employ it and use it as part of their adjunct as well. So I think in that, and then the biggest one, I think, by far, is the undifferentiated dyspneic patient. That is like where you have the most challenge. And that's what we face in the emergency department as well. And that's the first thing we do. We say, let's look at the EF, let's look at the lungs. And that's predominantly where I find ultrasound to be so huge as far as changing my management practice. And if we can change management practice 20, 30 minutes before, in the field, we're really changing outcomes. And that's kind of where it really makes a difference. But you're right, but the dyspneic patient, we get calls for dyspneic patients all the time. And that's kind of where I think the utility is there. And I'm also kind of, I was looking to see whether they would look for B-lines and whether they would look, and they didn't. And I was really hoping for that. Versus pneumothorax, sure. But much more relevant is your dyspneic patient. And that's where that would have been a little bit more clutch to getting.
Yeah, absolutely. So dyspnea, certainly there's utility. Heart, lungs, IVC is what our protocol is in the emergency department. And you make a great point. For trainees, oftentimes my practice is to challenge folks to come up with a reason to scan every patient. And it may not be diagnostic, but certainly we can find reasons, actually acquire studies, work on our training and skills, and ultimately design those studies for the highest yield diagnoses or chief complaints or call types that we could potentially make an intervention. So Bob, you actually pull these statistics for us. Within our system, we apply CPAP about a little bit less than 1,000 times per year. And we have good systemic reviews and meta-analyses on this, that early intervention with CPAP at the pre-hospital level can significantly reduce the rate of intubation, and that has a direct correlation on overall morbidity and mortality, because we know that for patients that are that critically ill and get intubated, they have complications later on in the ICU, whether it's ventilator-associated pneumonia or longer days on the ventilator, or greater ICU days, and nosocomial infections, etc. So if you can mitigate or prevent that intubation, one, you're already placing them on CPAP, and now you already have a better idea with ultrasound, whether it's heart failure, COPD, or something else. You can start your intervention that much earlier. Whether or not that's going to have any outcomes difference, we have to do a lot more prospective studies. So interesting stuff, and hopefully we aim to do some of that here with some trials on ultrasound devices, which are becoming increasingly more portable. So tablet ultrasounds, very light, very rugged, and great image quality acquisition with physician QA review, et cetera, et cetera. Cardiac arrest is also very interesting too. One more point on CPAP. So CPAP now, I think this study looking at EMTs was fantastic, because now in New Jersey State and New York State, CPAP is approved to be within the scope of practice of BLS providers. And for any EMSNation folks that are listening on the podcast, if you are in another state or another country, for example, and you're at the EMT level and you're using CPAP, please tweet us and let us know your experience. But that's something that we know is going to be gaining a lot more use at the BLS level, CPAP, because of suburban or rural areas with prolonged transportation times, that may provide significant benefit to those respiratory emergencies. Josh, would you, as a paramedic, be open to learning ultrasonography, or do you think it would waste time and be an unnecessary skill?
Absolutely. I could see ultrasonography would be great for just about every patient out there.
What other
75% of our calls are breathing difficulties of some sort.
Chest pain, respiratory distress, even with the placement of an IV potentially?
Correct. Placement of an IV would be the next step that I wanted to bring up, but I noticed nobody wanted to talk about that. Number one problem you have is when you have a patient in PEA that you're not sure if they're in a PEA.
Absolutely.
And you're watching on a monitor a heart rate of 90 or 100, great rhythm and no pulses. Ultrasound is your obvious go-to mechanism for that. Then you've got the differential between CHF and COPD. And then all the other issues that come up that ultrasound just pregnancy patients, I mean,
Absolutely.
is obviously one of our bigger ones.
Yeah, we have case reports on how pre-hospital ultrasound can change outcomes with acute obstetric emergencies as well. So interesting stuff. Cardiac arrest. You bring up cardiac arrest. As you guys know, PEA is one of our pet peeve terms in the sense that the patient is having organized electrical activity. However, likely their cardiac output is not significant enough for us to palpate pulses. And obviously there are challenges there pre-hospitally. So using ultrasound in identifying reversible causes of cardiac arrest. So getting an idea of what your myocardium is actually doing in PEA, finding out if there's a large effusion or potential tamponade physiology, taking a quick look at the right ventricle to see if the patient may have an acute pulmonary embolus, seeing if there's any concomitant pneumothorax. And certainly our hope is, as we proceed or develop this science, to even potentially start using transesophageal echo pre-hospitally as a physician-based program, because it would allow us to do continuous monitoring of the heart without ever interrupting chest compressions. And we know more and more emergency physicians are incorporating TEE into their clinical practice. Mainly Dr. Arnfield just published a great review article, and he's in, I believe, Ontario, Canada, and has set up an aggressive TEE program there. And then also in Mount Sinai in New York City, Dr. Brett Nelson is doing a great TEE program there. So it's only natural with the development of EMS response physicians that this may have potential application pre-hospitally. What about ECMO? Can we use ultrasound to potentially help us for ECMO?
Yeah, sure, absolutely. This article is great because it looks at the paramedics and basics, and obviously, there's utility with physicians because we're well trained in ultrasonography. But then the next step is going to be, okay, so now that we want to employ this, but now, the competency and the training is another issue. In order for you to get reasonably comfortable, on average, it's going to be at least 25 to 30 scans that you have to have done.
Absolutely.
To get at least minimally comfortable in interpreting and being able to use your hand and augmenting it to what you see on the screen, and then getting your views that you need. And then when you have a large EMS system, that correlates to large amounts of training time. So
training time and training dollars.
Absolutely. Yeah. And again, the only way you're going to really perfect this art is on patients. So, being able to do this, being able to do 30, cardiac ultrasounds, and each paramedic doing 30 cardiac, that's quite challenging.
Yeah, I think most studies that study this, or even our aim to prospectively study this, would be to bring the providers into the emergency department, where we could effectively teach them normal, allow them to do several independent scans, and then review those scans with them to ensure competency, which, the larger your EMS system, the larger the cost.
Yeah.
Some folks are doing very specific introduction of ultrasound in pre-hospital, and that's specifically HEMS programs, so helicopter EMS programs, as well as critical care transport programs, in the sense that you have a more subspecialized paramedic or pre-hospital care provider, whether it be a nurse, etc. You add the additional application of trauma and the FAST exam. And then you have a smaller subset of providers to train, and they're doing it more often and have overall more critically ill patients.
However, in ultrasonography, a significant part of your learning curve is actually seeing healthy patients. And it's possible in ultrasonography to practice on each other. Therefore, you can get 30 or 40 scans simply in practice, as opposed to, for example, intubation. You can't practice intubation on a healthy individual. So you're never really getting the practice that you need in intubation unless you have a patient that's not breathing in the field. So ultrasonography is a significantly easier way, skill to teach, practicing on healthy individuals.
Yeah, another point there is simulation. We talk about simulation and getting enough practice intubations to make sure that you have retention of your skills. And we always talk about the foibles of using a simulation or rubber mannequin to practice your intubation skills that may not be the most robust. But we very interestingly have new companies coming out with using RFID technology to employ simulation of ultrasound within mannequins too. So in other words, I have a mannequin, I'm doing high fidelity sim already in my shop using various RFID chips. I believe the company is called SonoSim. And I can create all sorts of pathology within my patients, and I would require my medics to scan in the appropriate location with appropriate technique, and only then would the pathology be revealed. So you can use a high fidelity or a low fidelity mannequin, even I suspect, to do all sorts of ultrasound simulation scenarios. So great, interesting stuff. A lot more to come, especially in the disaster field, potential USAR, urban search and rescue applications, potential helicopter EMS applications, and we'll continue to develop the prospective literature base to see if this becomes a mainstream phenomenon. All right, next article. So highly controversial, CPR and mechanical devices. Have we not talked about this enough? Don't we know the answer to this question already?
So, this is the review article, Cardiopulmonary Resuscitation using electrically driven devices, and this is a review. We're looking essentially at cardiac arrest and looking at employing mechanical compression devices versus good old-fashioned CPR done by healthcare providers. So that being said, we're looking at two specific devices in this review. And the two specific devices that we're looking at is, one is the Lucas, and it actually stands for London University Cardiac Assist System. And essentially what this is, and I think most of us are familiar with this, is basically the pneumatic cylinder mounted on two legs, connected to a stiff back plate. And essentially it has a suction cup. The suction cup goes basically in the sternum. And then essentially you deploy the device, and essentially it starts mechanical compressions. It's already seated to do basically compressions at a fixed rate of 100. And the depth is pretty much set at, I believe, 2 centimeters. And so essentially
2 inches.
2 inches, I'm sorry. So essentially the device, there's a Lucas 2 out, so that's pretty much what's mainstream that we basically see out in the fields, and we see a lot of healthcare providers using this. Essentially there's two thought process behind this. One is basically forward flow. You're perfusing, you're basically causing compression, direct compression of the cardiac, it's the heart itself, and that's causing forward flow, and that's causing coordinated perfusion. And then you have this kind of phenomenon of this compression decompression phenomenon, and there's essentially, because of the change in the interthoracic pressure, you're causing forward flow and coordinated perfusion. So based on those kind of two rationales, you're kind of perfusing the heart, or the heart itself. And really that's kind of the premise behind this device. And what they really looked at is looking at overview of really recent publications. So we've had 6 or 7 studies basically looking at the Lucas device. And initially we first had these first studies that came out in 2002 that showed that the Lucas was superior in compared with mechanical CPR. But as we've had more studies done, in the past, probably 10 years now, we're now seeing that, Lucas is not superior compared to manual CPR. And Lucas does not seem to achieve higher cardiac output, and it's just not statistically significant. And at the end of the day, it does not improve survival. So what is the Lucas doing? Well, the Lucas, what it's doing is creating great maps. So you're getting good maps. And I mean, I personally have seen it when I've had patients in the coronary care unit, and they have A lines in, and you see them doing compressions. You're seeing great compressions. You're seeing maps of 50s. So these patients are perfusing. However, there still isn't good outcome data. And we talked about this a lot, where you may achieve more ROS, but at the end of the day, just because you're achieving ROS, what is the primary end goal of end mortality? At the end of 30 days, 60 days, it's unchanged, and it's not statistically significant. So ultimately, as they've reviewed basically these devices, the same kind of reoccurring theme comes about, that basically they're not statistically significant, and they do not improve mortality. So that's basically what they've kind of summarized with the Lucas device. The second device they're looking at is the auto pulse. I grew up knowing this is a thumper. I personally, when you look at the Lucas and the auto pulse, would rather have a Lucas on me than that thumper, because that thumper looks painful. And you just look at it, you just cringe whenever it's running. I mean, that's just me, but I've never been a big fan of this. But this is a low distributing band, and this is basically has a backplate. There's like a mini backboard, essentially what you have, and they have these bands that come on. And essentially the device itself provides 80 compressions with a depth, basically 20 to 30% of your thoracic circumference. So it's really it's not measuring a specific depth by inches. It's what it's measuring actually is a relative percentage based on the band itself and how much it's coiled up on the patient. That's kind of the premise behind this device. And essentially they basically compress, and a lot of times you've seen a lot of significant trauma that comes from this. And there were studies that were done with this specific device where they actually terminated the study because they were seeing worse neurological outcome and a trend worse survival in these groups. So, there was a study by Hallstrom that actually they ended up terminating the actual study altogether because of the fact that they saw these. So when you look at it, when I say that, it looks very painful, it looks pretty like it's causing a lot of trauma, the trauma created secondary to the autopulse versus manual CPR, there weren't any statistical significance, but nonetheless, it does look pretty scary. And again, studies basically show, again, they're equivalent. There's no basic change really with the autopulse as well compared to manual CPR. So both of these devices, they're not really doing anything. And I think this article didn't really address this well enough. They just kind of left it at basically their conclusion, which is it's essentially not superior and it's not recommended. But we always talk about why, we love the device because, again, we talk about, a person who's doing CPR, within 1 minute you start getting fatigue, and that's why we're rotating people out every 2 minutes. We know that you can't sustain the same frequency, you can't sustain the depth compression. So all these variables are coming into play, and we now know that, compression frequency, depth frequency, that all matters, and that all changes mortality. So, having a device that sustains the same amount and the same frequency is very, very important. But again, we kind of look at the numbers and we're like, these don't make any sense, despite the fact that we all like this device and we all want these devices to win so that we can use them. But ultimately, that one study we had looked at, an average time of 36 seconds to deploy these devices is really what is the biggest downfall. You can't wait an average time of 36 seconds to deploy a device and no CPR going on. So ultimately, this is kind of where these devices fail, because we're causing more mortality by stopping for half a minute to really put this device on. Where I feel that these devices are superior is when we've attained ROSC, we can put these devices on, so if we lose pulses again, we can start immediately. And now we're actually ahead of the game. Or when we're deciding to transport, if we're on a second floor going downstairs, in a stair chair, we can sit there and employ the Lucas device, and it's still working. When we're in the back of an ambulance, we should be secured ourselves, and we should have a Lucas device going on and actually deploying CPR. So, these are the times when I feel that, it's far more superior. How many times have I seen a patient come into the ED and you have a medic on the side with one hand just kind of doing compression? So that whole, 2-minute interval of them going from the back of the rig into the ED itself is detrimental to the patient. So, these devices have a role, but I think it's a very specific role. And I feel like if you're on scene and you're going to stay in play, mechanical CPR is not the way to go.
Lots to discuss, Dr. Davis.
I was just going to say that I think the two key things that you mentioned, one that you mentioned, one you maybe didn't, is that provider safety in transport is key.
Absolutely.
Way too many tragedies of people getting thrown about the ambulance and getting injured of the providers. And I think the device is certainly useful for that.
Sure.
Because it's not inferior, basically equivocal. And the other thing is for very prolonged resuscitations, hypothermic patients, things like that, where it's just impractical to have somebody doing CPR, a team doing CPR for 5 hours or until you warm them up.
So that's something we don't talk about often enough, I think, is the safety of the pre-hospital care provider. And let's say we have a case, excellent pre-hospital care, both at the BLS level, ALS level, ROSC is achieved, it was a witnessed arrest with bystander CPR. So this is a potential salvageable patient, and when we say that, we mean intact neurologic discharge and retained quality of life. So now you have a highly tenuous patient in the back of the ambulance. We worked the patient on scene, decided to transport, and the patient re-arrests, right? So what do we do here? This is potentially dangerous, and I think we are saying that high performance CPR may be the ideal option when we're on scene, and for transport, backup with a mechanical compression device may be, in fact, a really good idea. And I know that ILCOR, the International Liaison Committee on Resuscitation, just published some new guidelines, which we'll link in the show notes, that comment on high-performance CPR being your baseline, and for transportation, considering the use of mechanical CPR. And provider safety, especially in the back of the ambulance, is something that's very important. Do we, if you have a post-ROSC patient, are we going lights and sirens? How are we coding this, Bob?
We're not doing lights and sirens really on anybody.
Yeah, absolutely. So that's another thing that's way overused is the emergency response lights and sirens, which has confer significant danger and to our providers. Yeah. All right, great. What else?
In any situation, you can always say that if somebody's not well trained in using a device, that the device is not going to work properly. And if it takes you 36 seconds to a minute to put on a Lucas, then you're absolutely correct in saying that is detrimental to the patient's health. However, when properly trained, and even in the demonstration that we had here, we were able to put on that Lucas with less than a 5 to 7 second delay. That being the case, then the Lucas has significant advantages. For one is, it is impossible for someone to do CPR unless they're in amazing shape for any significant amount of time. So what you're going to end up doing is switching CPR providers every 2 to 4 minutes. That in itself is a tremendous detriment to the patient because there's a time differential between each provider. And as we know, with every 5 seconds that we stop doing CPR, there's a 7% greater chance of mortality. So if we can get that Lucas device on and not be dependent on the different potential of each specific provider, that will give us that much greater possibility of ROS and possibility of coming back to a significant, walking out of the hospital. Now, we've found in our studies, not that we've done formal studies, but on Hasala, for example, we have had significant good outcomes with the Lucas device. We have a number of patients out there that have been through cardiac arrest, have had ROS, and are now walking around and living a productive lifestyle. Part of this study doesn't take into account how long it took to get there, how quickly they got the device on, when they started CPR, what was the patient downtime. So all of these things, yes, certainly, if you had a patient that was down for 10 minutes and then you started CPR and then you put on a Lucas device, your outcome may not be as great as a patient who had a witnessed arrest and then had the Lucas device on within, during a 5-second interval in the middle of high-performance CPR. I mean, your outcomes are going to be significantly different. And we keep coming up with the same conclusion that there's no greater outcome using a Lucas device than there is using mechanical CPR. But there are so many variables in there that the whole study becomes moot. And therefore, I'm still a big advocate of being able to allow the provider the ability to do other things on the patient and let the Lucas device do strong and steady CPR.
Is that one of our confounders in any cardiac arrest study, though?
Absolutely. So lots of great points there. So let's take them one by one. So Josh, the first thing you mentioned is that there's a steep learning curve for the application of the device. And we should state that we have no commercial interest in any of these devices, but we have trialed the Lucas device specifically within our service. In fact, the main variable which was dissuading us from the universal application was the 36-second application time. So when we trialed the device, in fact, it took us a long time, and we're just using plain mannequins, moving bodies around. We tried various different positions. It took a significant amount of time to initially apply the device. And with one of our former fellows, Dr. Westrel, we in fact spent 3.5 hours. We spent one morning just working on various scenarios and applying the device. And after several hours, we were able to get it down to about 7 to 8 seconds. And we timed it, and we're pretty proud of ourselves. But again, we acknowledge that there are different variables are going to come into play with real patients, not just mannequins. The concept that you're alluding to, Amandeep, is the CCF, the chest compression fraction, which is the area under the curve, the percentage of the total percentage of time that high quality CPR is being performed during the course of the code. And the initial delay of 36 seconds significantly reduces the chest compression fraction as opposed to initiating high performance CPR from the outset, right? It takes somewhere on the order of 5 minutes for mechanical CPR to catch up in terms of CCF as a variable to high performance CPR. And another one of the interesting data points we've uncovered in these studies is one article we reviewed was a Norwegian or a Swedish study where they did describe the initial time of 36 seconds after repeated and scheduled simulation, including in situ simulation in the field. They were able to get their device application time down to 7 seconds on average, which is a significant improvement. And we don't have the prospective data with the new sets of variables, in the sense that now that I've been trained on this device, let me go forward and compare it to high performance CPR. The flip side of that is the standards here, or the comparison groups, are high performance CPR. Sometimes we colloquially refer to that as pit crew CPR, in comparison to the mechanical compression devices. And with the advent of direct feedback during cardiac arrest with a puck device or a feedback device, all the major monitor companies produce them, Zoll, Physio, as well as Philips. We've actually retrospectively reviewed data from all sorts of different systems, and we found that the quality of CPR is highly variable in the United States of America. In other words, not everyone is getting or receiving high quality CPR. And when we talk about principles of paramedic education, should we not be able to walk before we can run? In other words, some services are reporting acquisition of this new technology and significant improvement in their outcomes. And so almost cynically, my first question is, well, were you performing high performance CPR in the first place? Was that your baseline? Did you train for that? Did you measure that? And we're getting more and more data with chest compression fractions for cardiac arrest. And we're finding, in fact, the ITD study, which was randomized, prospective, double-blind, multi-centered, New England Journal article, as best as you could possibly construct, showed no difference in outcomes. And coincidentally, they went back retrospectively and reviewed the quality of CPR and found that there was a significant variation, which was compromising their results. And we, in fact, had a retrospective analysis done by Dr. Yiannopoulos, and Dr. Paul Pepe also cited that, which said, well, if CPR is high quality, high performance, the patients ended up improving with the active compression, decompression, and ITD, whereas if CPR was poor quality, they, in fact, ethically, challengingly, had worse outcomes, right? So quality of CPR really seems to be the main crux, as well as training and your overall chest compression fraction. So how do we sort of encapsulate that in our training protocols?
And that's one of our main issues. And that, with our type of system here, that we interface with so many different agencies, the quality of CPR between agencies is highly suspect.
Highly variable and suspect, yeah.
And if you look at an agency that's able to do like this longitudinal study to say that before we introduced high performance CPR, we have data. And then after the majority of our people were trained and this became our policy, we have new data. If you don't have an organization that does that, which probably describes the majority of responders in New Jersey, you don't know if introducing this device in any given agency is going to make a difference or not. But certainly for those who aren't currently under a program of high-performance CPR, that would be a really interesting study to do. And what I fear is that we'll see people, back in the 80s when they introduced the electronic BP cuffs and people suddenly realize, I don't have to learn how to take a blood pressure anymore. I don't have to understand how it works. I never have to do it again. Until many people found that those were not reliable blood pressures. And then you had a whole generation of EMTs that only knew how to put on an electronic. Is it something that is good for our patients if we're not doing it right? Or would it be better for our patients if we learn to do it right in the absence of a device and introduce the device?
I think that's a great ethical concept, is if you're deciding whether to introduce a device in your service, should you not do a review of your cardiac arrest, a QA/QI review, and ensure that a large proportion or percentage of your providers are performing CPR at a high quality? Is that not an ethical implication of buying this device? Or even say if you want to buy the ITD or active compression decompression, you have to have high performance CPR to begin with for the device to actually be effective.
I was going to say that I think this makes it incumbent upon us to add one more job title or one more task to our already long task of what we need to do, and that is that at every single intervention, every single interaction amongst hospital staff, amongst BLS providers, amongst bystanders, we also have to be in as supportive and collegial way as possible, educators every single time. Mm-hmm. And we need to be on them saying, we're not stopping CPR check for a pulse.
Absolutely.
Because we have continuous pulse ox monitoring. You've been doing 2 minutes.
Right.
That's right, entitled CO2. You're doing continuous CPR for 2 minutes, switch out. I know you're a bodybuilder, I know you're a cross-country runner, you're tired, switch somebody else out. And we have to do that in a supportive and educational way to really bring all providers up to the standard that we expect with high-quality CPR.
Absolutely. So taking the ego out of CPR, I think that's something we don't talk about very much at all. And CPR in a pit crew formula can be run by the team leader is a BLS provider, right? But that person or that individual or that agency needs adequate training and experience to perform that effectively. And I think active QA/QI, if the agency has the resources to do it, and analyzing now each team's chest compression fraction can be remarkable in improving cardiac arrest outcomes, right? And we notice the wide variability. Why do Seattle and the Twin Cities, for example, have better cardiac arrest outcomes? A whole host of reasons. But drilling in high-performance CPR and bystander compressions is a huge factor. What about, we haven't talked about the ability or some of the technology regarding see-through CPR. So hands-on defibrillation has been a huge conversation that we've had and we've enjoyed and bantered about in this group. But with the mechanical devices, I can potentially shock through the devices without interrupting compressions. What are your thoughts there?
The auto pulse doesn't like that.
Okay.
It shuts down when you do that.
So some variabilities in the device itself.
Actually will read the pressure, the movement as a pressure change and will go into standby.
Sure, but Josh, you're saying?
Lucas, however, will keep working. One other point, though, just to consider on what Margaret said earlier, is that even if you've gotten the CPR down to a science and you've got the greatest CPR providers, every switch involves some level of loss of time, no matter how good you are. And B, like Faizan was saying earlier, when you transport the patient, if there's a decision that, okay, we've done all we can do, we have good circulation, we had moments of spontaneous ROSC, we need to transport this patient, the movement of the patient and the transport of the patient will significantly impact the continuous high-quality CPR.
Absolutely.
No matter how good you are.
Absolutely.
And in those situations, only these devices can continue high-quality CPR.
That's a great point. I think another point that we don't yet know, and we're only just beginning to experiment with this thought, is we're not quite sure how to identify the appropriate patient, but let's say we're working the patient on scene, they remain in arrest. Can we now start a mechanical compression device and bridge them to the emergency department for ECMO? And that's a question that we have not enough data on to answer. It's not currently the standard of care, but we have a lot of science suggesting that may become an experimental modality within the next 5 to 10 years, certainly. And we may even be initiating cannulation in ECMO pre-hospital, either physician-based or critical care paramedic or flight-based. So there's a lot of potential for mechanical compression devices when they're tied together with the concept of initiation of ECMO that we don't know a lot about. What do you guys think about that?
I mean, it's all about getting your receiving hospitals kind of in line. And you got to change that. You got to have, these heart failure interventionists and these cardiothoracic interventionalists kind of on page with kind of this resuscitation modality. And that's kind of the biggest struggle that we're going to have, is being able to, have that interface. Now, the ECMO machines are getting smaller and smaller. I don't even think we have to cannulate. If we have these devices, we can just start ECMO in the field because they're so portable. But that being said, if you take it to your receiving hospital, one, do you have because, every ECMO device has to have an ECMO, the perfusionist there. So you have to have the perfusionist available there on site, at the time that you're there. Depending on what facility you're at, they may not have one. And so that's where, you start having these challenges of just the ability to, for facilities to actually, support us placing people on ECMO.
Yeah, when we're in San Diego for NAMSP, we should perhaps see if we can schedule a visit to Sharp and see what those guys are doing with ECMO, because they're certainly one of the leaders in the U.S. And I know Dr. Weingart is planning a resuscitation conference, a reanimate conference in February there as well. So it may be worthwhile in January while we're out there to pay them a visit. Any other thoughts? All right, thanks, guys.